Hi, everyone. My name's Matt, and today I'm going to be talking to you about LVADs and the ED, the kind of complications they have and how these patients present. So the talk is divided into four parts. First, we're going to talk about the device itself. We'll talk about patient-related problems, then problems that are related to the device, and then how to assess and manage those things. So let's start by talking about the device itself. So you've got this pump, which rests directly at the apex of the LV, or it's connected, and then it pumps out this outflow tubing that goes into the ascending aorta right there. So this is what that part looks like. You can see here, that's the part that goes into the LV, and then it sucks the blood out. There's a magnetically levitated thing here that rotates, and that's how it generates the flow to go out the outflow tract. This is a view of a different device. You can see how this is the inflow, this is the outflow, this part's magnetically suspended, it spins around, and that's how it generates the flow. So the other parts of the system, besides the pump itself and the outflow tubing, you've got this cord. This is what comes outside of the patient. It's called the drive line. It's connected to the controller, which is the computer that's controlling the pump and monitoring it. And then it's attached to these two batteries. Now, it's not always super obvious when a patient is wearing one of these. There's like this whole industry of Etsy stores that are designed to sort of concealed carry your LVAD. So this guy is actually he's an LVAD patient. So he's all dressed up and wearing this stuff to help him wear this discreetly. And there's, other things they sell like this. So like this guy over here is like, hey kid, you want to buy an LVAD? And the hard part about this is in a study that I did where we looked at pre-hospital encounters with LVAD patients in San Diego, EMS was not aware that the patient was an LVAD patient about a third of the time. And that's largely due to this kind of concealed nature of it, where the patients, they don't want to sort of outwardly show that they're wearing it, which falls into that typical sort of, oh, do you have any health problems? Oh, no, So let's talk about the device a little bit more. So the device itself, you're going to hear me say this over and over and over again, because it is the foundation to understanding the hemodynamics of an LVAD patient. It is preload dependent and afterload sensitive. And we'll talk more and more about what that means. Now, the pump itself, it only does four things. It's not as complicated as you think. It turns on, it turns off, it goes faster, it goes slower. That's it. Everything else about the pump is just sort of fancy versions of this, but it's a pump. That's all it does. It starts, it stops, it goes faster, it goes slower, period. So now about the patient. These are advanced heart failure patients. They will receive the LVAD for one of three indications. One is a bridge to recovery, which means they anticipate the patient's going to get better and the LVAD can be explanted at some point. This is typically like your young patient that gets like a myocarditis and they have the VAD for a while they recover, and eventually it's taken out. Bridge to transplant, which is pretty self-explanatory. We're trying to prolong the patient's life and improve their quality of life while they're awaiting transplant. And then there's destination therapy, where these patients are not eligible for transplant. We know they're going to be dependent on the device, and they will eventually die with the device. There's nothing else to offer them, and this is a life-improving and a life-prolonging, you could almost call it palliative treatment. All of them are going to have a pacemaker ICD. They're all going to be anticoagulated on Coumadin with INR of 2 to 3. They're going to have an acquired von Willebrand deficiency from the blood going through the pump and sort of being mechanically chewed up. And for the most part, these are continuous flow, meaning that the blood is moving continuously. It's not pulsatile like the normal flow of the heart. Now, the HeartMate 3, which is the current generation device that's being implanted at Bay State, that one actually spins up and spins down, I think 20 or 30 times a minute to simulate pulsatile flow You won't be able to palpate that, but that pulsatile flow has reduced some of the complications associated with LVADs. In the prior generations of LVADs, they were prone to getting different kinds of AV malformations, which they determined was because the gut just does not like continuous flow. And so since they've added this pseudo pulsatile flow, they've reduced the incidence of AV malformations and some of one kind of GI bleed that occurs. So let's talk about patient-related problems. Though the vast majority of these patients are going to be presenting for a problem that is pretty straightforward: bleeding, infection, and CHF exacerbation, which makes sense because these are advanced heart failure patients that are anticoagulated, have an acquired von Willebrand deficiency, and they have a foreign body in their body with a port to the outside world. 2/3 of their presentations can be summarized as chest pain, syncope, CHF, neuro, fever, GI bleed, which is all stuff that you know how to manage already. In these cases, the VAD itself is an innocent bystander. The device is functioning fine. This is all patient-related stuff that has to do with them being an advanced heart failure patient that's anticoagulated. Now, notably, device-related alarms or malfunctions, in this study at least, made up less than 5% of presentations. And we'll talk more about device complications in a minute. But the point I want to make is that 90%, more than 90% of the time, this is a patient problem. It's not a VAD or a device problem. Still, in these cases, even though it's nothing to do with the device itself, your step is still to call the VAD coordinator. And that's for a number of reasons. Number one, they know these patients very intimately. If a VAD patient is showing up to the ED, it's probably because the patient's already called the coordinator and the coordinator told them to come to the ED. So they're already going to have a good idea of what's been going on and what needs to be done. So further breaking down some of the causes and the categories of patient-related problems. There's cardiac things, which, as you would expect, are things like arrhythmia, volume overload, CHF exacerbation, hypovolemia from overdiuresis, aortic regurgitation, which is a very late complication of having an LVAD, which we'll talk about later, why that's significant, and RV failure, also a very late complication of having an LVAD. And you would treat those just as you normally would. Bleeding things, GI bleed, epistaxis, and CVAs. So from a bleeding perspective, with the CVAs anyway, still more likely to have an ischemic stroke rather than a hemorrhagic stroke, but they're more likely than the general population to have a hemorrhagic stroke because of the anticoagulation and the von Willebrand deficiency. But still, generally, they have a higher risk of ischemic rather than hemorrhagic stroke. And also, in the presence of even like a mild trauma, I'm definitely going to be CTing these patients' head to look for any evidence of intracranial bleed. And then infectious things. Early on, there's the pocket that the device is sitting when it's implanted can become infected. And later on, the drive line coming out of the body can become infected. And of course, they can get septic just like anyone else from any other source. They can have pneumonia, UTI, bacteremia, skin and soft tissue infection, a CNS infection. They can still get all that stuff. So there are a lot of these complications that can affect preload. And when the preload drops, the VAD doesn't function as expected. So things like an arrhythmia, because you lose the atrial kick, hypovolemia from overdiuresis, or RV failure, GI bleed, even severe epistaxis, those things can drop the preload enough, and now the VAD can't function. It can't produce enough forward flow. Now, in infectious problems, you may develop septic shock, which is a distributive shock. And so that drops the preload. And either the pump would need to be adjusted to accommodate for that, or you need to start pressors so that you're getting the preload that the VAD is designed, that is optimized, the preload that the VAD is optimized for, so you can generate the correct forward flow for the patient. And also, if you're starting your pressors, you can't overshoot. that map target, because if the afterload is too high, the VAD won't be able to pump against the resistance. You won't get enough flow. One more thing to think about with epistaxis or other GI bleed is that they're anticoagulated and they have a von Willebrand deficiency. So in discussion with the LVAD team, you may give them DDAVP to try and improve bleeding before you actually decide to reverse their anticoagulation. So let's talk about device-related problems. This picture here is from a case study where a LVAD patient's driveline got severed, and the ED attending, who was a former electrician, spliced the wires back together to get it back up and running. Now, when you have a device problem, definitely, even as in other cases, your first step is to call the VAD coordinator, because they're going to be able to help you troubleshoot the device. Now, when a patient presents for a VAD-specific problem, it is usually because of an alarm or an abnormal reading on the VAD's kind of performance dashboard. And the usual result is an adjustment in their anticoagulation. So the device problems that we need to think about are suction events, thrombus, the VAD is not running, or cardiac arrest. Now, a suction event is an earlier on complication, but for some reason, that's the one that tends to appear more on the boards. And in reality, between these two very rare complications, suction and thrombus is the thing you're more likely to see in the wild. Now, a suction or a suck down event, again, this is an early complication that tends to occur immediately after implantation, usually while the patient is still in the ICU. This is because there is not sufficient preload for the pump speed. And in a recently implanted VAD, this can be because the pump speed is set too high. But later on, it can be because the patient doesn't have enough preload. They got over-diuresed or something, or they're bleeding or otherwise volume down. Now, what happens here is the pump speed is too high, so that inflow cannula gets sucked towards the septum, the ventricular septum usually, and it kind of gives it a hickey. And the controller understands that there's no flow now at this point, so it stops the pump temporarily so it'll come off and then restarts it. So there'll be alarms going off. If you were to be auscultating, you'd actually be able to hear the pump stop spinning and then resume spinning. To prevent this, when the patient has the VAD initially implanted, they do what's called a ramp study, where they take them to the cath lab, they put in a bunch of pressure transducers, and they adjust the speed up and down to see what that does to the pressures and the hemodynamics for the patient, and then they set that patient's RPMs based off of that. So the treatment for a suction or a suck down is going to be giving them more preload, either in the form of fluid or volume. So again, remember this loss of preload that makes the VAD malfunction. That's because the VAD patients are preload dependent. Now let's talk about what exactly that means. So this is your normal Starling curve. Is you add more preload, you get more cardiac output up to a point. This is an LVAD patient Starling curve. At a certain point, below a certain point, you just lose your cardiac output, right? It can't function. So it needs a certain amount in order to function. But as you add more preload after that, you don't get more cardiac output. So LVAD patients are preload dependent, but they are not preload sensitive, meaning that if you're trying to improve their cardiac output, if they have enough preload, giving them more doesn't help. So let's move on to talk about thrombus. Now, thrombus really became a concern between about 2010, 2015, when there was a big spike in this as a complication. That turned out to be related to specific parts of the second generation devices that have been modified and are no longer present in the third generation devices that are now being implanted. So by and large, the pump thrombus is extremely rare in modern times. And it doesn't really happen because the issue that caused it has been designed out of the newer devices. But if it does happen, it's a much later complication, and it may happen because of issues with anticoagulation, noncompliance, or something. Now, when it happens, you have a blood clot that's forming in the pump, so there's going to be a lot of extra resistance, and because of this, the controller may get hot, or you may see that it's drawing a lot of power, an abnormal amount of power. Part of the diagnostics for this is getting hemolysis labs, which is going to be LVH and haptoglobin. On echo, you may see dilated RV and LV, depending on exactly where the problem is. And the treatment for this is going to be heparin or TPA in coordination with the VAD team. So if the pump is not running, again, first step is to call the VAD coordinator, but your ABCD assessment for a VAD patient is auscultate, battery, controller, driveline. So auscultate to see if the pump is running. And then if it's not, then you're going to check the batteries, the controller, and the driveline connections. So let's talk about the LVAD patient in cardiac arrest. Your number one goal, if the VAD is not running, is to restart it. If the VAD isn't running, you essentially don't have an aortic valve because you now just have a tube connecting the LV to the aorta. So as you do chest compressions, you're going to have the same column of fluid moving up and down rather than having a valve in place to create forward flow. So CPR is largely ineffective unless you restart the VAD. Now, if you are unable to restart the VAD, there is actually an AHA recommendation to go ahead and do CPR. The concerns about dislodging the VAD and that other stuff really had to do with larger, earlier generation devices. And now, based on the current literature, manual CPR appears to be safe. We don't know about mechanical CPR. We assume that it would be potentially more damaging to the patient. So in these patients, I would not find the Lucas device. I would just do manual CPR. You're going to do slightly modified ACLS. And I only mean slightly modified because you're only going to consider either limiting or reducing your dosing of epinephrine. Now, again, that's because the LVAD patient is afterload sensitive. So if you give epi, and you're getting all this contractility, all this afterload to try and improve pressures, it might be too much for the VAD to pump against. So that's really the only modification or consideration in these patients is either limiting the number of doses or reducing the dosing of epinephrine. And because this is going to be so difficult to monitor, like if they have a thrombus or something that led to this, I would really consider doing an intra-arrest A line to monitor the patient's hemodynamics in this situation. So let's move on to assessment. So first part of your assessment, step 0 is to call the VAD coordinator. Then auscultate for pump function. The second generation devices, you just hear a continuous hum as you hear the motor moving. The third, they spin up and spin down to simulate that pulsatile flow. You're going to check the batteries or call HVCC, or the coordinator will call HVCC to get the battery backup or the controller brought down. Fun fact, they only have 3 of these. So if there's 4 VAD patients in the hospital at a time, one of them is going to be getting their batteries changed out frequently. You're going to look at the controller, and the information that is relevant is displayed on kind of the dashboard that's on the screen. That's if there's any alarms, the current speed, the RPMs, the flow, the pulsatility index, which is a measure of how much work the native heart is doing, and the power, which is physically how much power it's drawing. These are the parameters that the VAD coordinator is going to want to know when they show up to the ED. And also worth noting that only speed and power are directly measured. Everything else is calculated. So the flow is based off of the RPMs. It's a calculation. So for example, if you have a thrombus and the pump is increasing the RPMs and drawing more power to try and compensate, it'll show a high flow, even though it physically has a reduced flow. You're going to check their blood pressure with Doppler in order to measure their MAP. We'll show a video of that in just a second. But if you have any concern that this patient is actually sick, just put it in our line. it's going to be the gold standard for measurement. So just very, very low threshold to just throw an art line in these patients for monitoring. Again, it's going to help you monitor the afterload, especially if you're starting the patient on pressors, to make sure you don't go too high and then reduce the flow because the pump can't work against that amount of afterload. We can do an echo, which we'll talk about in a minute, sort of assessing what an echo means and looks like in the context of a VAD patient. And if you're in trying to establish the patient's perfusion status, you're going to be looking for things like skin color, temperature, condition, cap refill. And remember, if there's no pulse, there's no problem. Labs, in addition to whatever standard labs you're getting, the VAD team is going to want you to get a type-in screen, coags, and then LVH and haptoglobin. They use the hemolysis labs to monitor their risk for developing a pump thrombus. So here is a video of someone, one of our VAD coordinators, measuring the blood pressure on an LVAD patient.
So first we put the then we're looking for the brachial. Looking for like a swish sound, just like that. You can always ask the patient where their sweet spot is. You're going to inflate the cup a little bit over where you stop hearing it. Once you hear it, hit your map. So 94.
So what she means by the patient can tell you their spot is because they get this measured so frequently, if you ask where to put the Doppler, the patient can show you. And also you noted the map that she measured there was like 92. That's too high. They really wanted to be sort of between 60 and at the most 80. So that patient actually ended up getting some medication adjustments while they were in the ED, even though it was for sort of an unrelated thing. So also take caution with non-invasive blood pressure measurement and pulse ox. Both of these rely on pulsatile flow in order to generate the accurate measurements that we have come to be accustomed with. But with non-pulsatile flow, they're not reliable. Especially, you might think that maybe the non-invasive would give you an accurate map or something. It doesn't. It's a random number generator. It cannot be trusted. And the pulse ox, again, because it doesn't have pulsatile flow, may not be reliable. So again, low threshold to throw in an art line or check an ABG if you're worried about oxygenation status. This is the VAD controller. This is the button that silences the alarms, and this is the button that toggles between the different screens on the VAD. So when you push it, it's going to switch between RPMs, flow, power, etc. If you push both of those buttons together, it's going to show you the most recent several alarms, and you can scroll through them because that's another piece of information the VAD coordinator may want from you. Now, I want to emphasize, it is impossible to turn this off if it is still physically connected to the patient. There are all kinds of interlocks that prevent you from doing that. You also cannot change any settings by pushing the buttons on this. You have to have the controller, right? It's like a pacemaker. So don't worry, you are not going to hurt the patient by pushing the buttons on the controller. So when, let's talk about echo and the kind of things we can see. So first thing to look at is chamber size. Now, most of these patients have a dilated cardiomyopathy at baseline. So if their chamber size appears normal, that's actually abnormal for them. Normally, you'd expect to see kind of a big dilated LV as you do in this picture. Otherwise, the RV aortic root, everything else looks fine here. So let's talk through how the chamber sizes could change in different conditions with an LVAD. So if we have low preload, we're having low inflow to both ventricles, and we could expect both the RV and the LV to be smaller. If we have an issue with RV afterload and there's RV failure or pulmonary hypertension or a PE or something, then we would see that change in RV to LV ratio that we're accustomed to thinking about already every time we look at an echo. If you have a big RV and a big LV, that could be indicative of a thrombus because now the outflow is blocked, and so fluid is backing up into both ventricles. And if you have a low flow state because of decreased afterload, for example, or because of increased afterload, and the LV is not able to effectively pump against it, you're typically going to see just the LV enlarge. Again, because the pump is afterload sensitive, that's why this occurs. So let's talk about the aortic valve. So this is an echo on a VAD patient. You'll notice that the aortic valve is not opening, and it should not open. Aortic insufficiency is badness and is associated with long-term complications. If the aortic valve is, if you have